celebrate Dr. Tara Schapmeyer. Is she around? Tara has just told me that she was elected as the president of the Association of Oncology Social Work. So when you see Tara around, congratulate her for that achievement, which is quite important. As you know, we always try to describe a few events in history or figures, historical figures that have changed the way we think about medicine and the way we consider biology and humanism and so forth. And so a couple of words about that. Today we remember Wilhelm Roux, R-O-U-X, who died on this day in 1924. He was a German zoologist who founded experimental embryology. He did a lot of work in frog eggs. And in the 1800s, 1880s, he started to look at frog eggs during fertilization and was able to separate the blastomere stage, okay, into two cells. And they continued, and he found that he developed two halves of an embryo. And he surmised that even as early as the two-cell stage, there's already sufficient information to determine the structure and the function of an animal. And that was very important to know at that time. And related to the theme of embryology, this is the day back in 1964 of the death of Alfred Blalock. And many of you have heard of Alfred Blalock because he did a lot of work as a surgeon, as a trauma surgeon and hemorrhagic shock. But he was also the first to devise, with a cardiologist called Helen Tucson, a surgical treatment for blue babies, tetralogy of Fallot. So he was the first to develop that surgery, and he did that on November 29 of 1944. He took a baby, connected the subclavian artery to the pulmonary artery, and did whatever the surgeons do, and the baby was no longer blue. So, but today is about the gut. What can Jesse say about the gut? Well, I found out that today was the death in 1932 of Sir Ronald Ross, R-O-S-S. He's an English physician, actually came to be the first British novelist, okay, Nobelist. He won the Nobel Prize of Physiology of Medicine for Britain in 1902. And he did it by studying malaria. And he was the first to find the malaria parasite in the gut of the mosquito. And later on, they find that mosquitoes transmitted this disease and was responsible for a number of diseases in Africa through transmission from mosquito bites. So with that, I'll leave you with Dr. Matt Cave, who's going to introduce our special guest of the day.
Thank you, Jesse. So I'm pleased to introduce Raj Vuppalanchi to the group and thank him for coming from IU to speak today on this important topic of drug-induced liver injury. So Raj is highly qualified to give this lecture. He completed his medical training at Gandhi Medical College in India and then came for internal medicine residency in the SUNY system in New York, and then completed a rather unique fellowship in clinical pharmacology at Indiana University, and then went on to complete his gastroenterology and hepatology fellowship there. So IU has a fantastic GI program. I gave a GI section grand rounds there Monday. Their transplant center is just booming. They're on pace to be the #2 liver transplant center by number in the United States this year. And so Raj is a part of that. Now he has unique expertise in liver pharmacology on both sides of it. So he's very active in drug development for diseases such as non-alcoholic fatty liver disease, as well as diagnostics. And after this lecture, he's going to give a second lecture to our GI section on new liver diagnostic test. But what he's going to talk about today is some of his work through the Drug-Induced Liver Injury Network, or DILI, and this remains an important problem in internal medicine. And every year when I go to the Society of Toxicology meeting, all the drug companies are there, and I can assure you this is a major problem that they're worried about in the process of drug development. And so without further ado, Raj, we look forward to your lecture. Thanks for coming.
Thank you for the kind invitation. I enjoyed the introduction. I myself am interested in old things. I do have a liver textbook from 1800s, and believe me, the whole book is about bile. So currently I'm reading a book, translation of old surgeries that were done in the Vedic times, that is 2000 AD, where they were doing rhinoplasty and stuff like that. So it's very fascinating, and sometimes we just rediscover things that have been forgotten. So my talk today is to share our experience about drug-induced liver injury and the recent issue about herbal and dietary supplement-induced liver injury that is not on anybody's radar. It's not talked about, so I want to make sure that I emphasize this issue. At the end of my talk today, I hope to impress upon you the following topics, which is recognize about intrinsic versus idiosyncratic drug-induced liver injury, the process that it takes to make a diagnosis clinically of drug-induced liver injury. Also recognize special situations such as drug-induced autoimmune hepatitis, which gets confusing. And we are increasingly facing patients who are developing side effects with drugs that are approved under accelerated approval program, a lot of novel therapeutics for oncology. And these drugs get approved with minimal safety issues addressed, and you may be the first guy evaluating the patient who developed a liver-related side effect that has not been described before. So we have to be very careful about these new drugs. What it takes to manage a patient with drug-induced liver injury, and this resource that is currently available free on web, which is Livertox, and it is the destination for drug-induced liver injury, and it should be part and parcel as PubMed when you look for, or current generation looks up UpToDate, but this should be very right next to UpToDate. Briefly, drug-induced liver injury could be intrinsic, which is predictable, reproducible, dose-dependent, and predictable histology when you do a liver biopsy. The classic example is acetaminophen. A lot of things have happened recently with regard to acetaminophen, which is the narcotics clubbed with acetaminophen dosage of 500 milligrams. FDA has recognized there is a lot of unintentional overdose, so they made a ruling that it has to be less than that. So currently it's at 325 milligrams. And also recognize the fact that acetaminophen is mixed with so many other drugs and available over the counter, and patients may be taking one drug in the daytime, one drug in the nighttime, not recognizing that both of them have a PAP, which is acetaminophen, and there could be cumulative overdose over time. So FDA has started a campaign called Know Your Dose, where you put in what are all the over-the-counter products the patient is taking, and it will give you a cumulative dose per day. So this may be something that may be very relevant to anybody in the audience or any patient anywhere who's taking over-the-counter drugs. Most of my talk today is going to be on idiosyncratic, which is unpredictable, it's rare, doesn't have a strong relationship with the dose of the drug, and on liver biopsy, it may show varied histologic presentation. This is the classic case, intentional Tylenol overdose. This is the Rumac scale. Patient comes in with overdose, the time of ingestion, time from the ingestion, and the liver enzymes are not very impressive, but there is acidosis and there is a Tylenol level, and you have the Rumac score. So this is 55, and you're looking at 20 hours, 55, and you know that the patient is going to be in trouble. You do the standard of care, but still there's fulminant liver failure and renal failure. This is something that's done in the ER. Most of the times this happens even before we see the patient. There's acute liver prognostic markers, which is King's College criteria, which is essentially giving numbers to what we think is severe organ failure, which is acidosis, kidney injury, coagulopathy, and encephalopathy. And these are the numbers that we all use to recognize whether the patient needs to be evaluated for liver transplantation. On the separate track is the idiosyncratic drug-induced liver injury. What we mean by idiosyncratic is unpredictable. Many people receive the same drug, but some people get the liver injury, and we don't know why some people get the liver injury. So that's idiosyncratic DILI. It's a single major cause of acute liver failure. It's the most common reason why a drug does not advance in the drug development. Millions and billions of dollars have to be abandoned midway these programs because of cases of liver injury that they recognize if it gets into the market, it's much bigger problem than losing the money in the drug development. Common cause of withdrawal or restriction, what we call as boxed warning or black box warning. Some of these drugs have been withdrawn even before I got into GI. This one I know some of you may be familiar. Telithromycin, it was an antibiotic, came brand new. It was called Ketec. I was in fellowship, and we recognized 2 cases that presented with jaundice and ascites, and we were convinced that this can't be drug-induced liver injury because patient had ascites and should be chronic liver disease. And soon after, FDA got reports, and when they summarized, they saw that this had acute liver failure with decompensation and ascites. That was the characteristic signature of the liver injury, and it was withdrawn from the market. This drug, zimaligatran, this was the first direct-acting 10A inhibitor, direct thrombin inhibitor, and AstraZeneca spent $1 billion trying to get into the market. They were first to the market, but there were 3 cases of liver-related death in phase 3, and FDA said, no, we cannot, even though your drug is going to be replacing Coumadin, and there's not been an innovation for the last 50 years, we are not comfortable approving the drug because of 3 cases of liver-related death in phase 3 trials. So it's a big deal with regard to treatment options and drug development and for clinicians. Right now, tolvaptan has been rejected twice because of concerns related to drug-induced liver injury. This is acute liver failure from ALF group. Here you see 46% are acetaminophen, and 11% are drug-induced liver injury, and 12% are indeterminate. Possibly some of these could be drug-induced liver injury. So it is something that's very important for us as a liver transplant center, and for you as a liver transplant center too. In drug development, thankfully many drugs are not getting into the market because of what the FDA follows. They are heavily dependent on these 3 points, and they have softwares that pick up these patients with abnormal liver tests that meet these criteria. One of them is, top one is Hayes law, which is based on Hy Zimmerman. He was a physician, and he was a father of hepatotoxicity. He suggested, based on his observation, that there's a 10% mortality when a patient develops transaminases 3 times the upper limit of normal, or bilirubin greater than 2 times of upper limit of normal with no other explanation. If a patient develops this kind of a signature with a drug, and if enough people are challenged with this drug, you have 10% liver-related mortality. So that's Hayes law. Temple's corollary is ALT imbalance, which is you have the treatment arm, you have the placebo arm. If you have an ALT 3 times upper limit of normal, the proportion of patients with that, if there is an imbalance, you know there's a signal for liver toxicity. Then if there is an ALT greater than 10 times the upper limit of normal, then that predicts 1 case of Hayes law. So FDA has advanced software programs. The company does a big phase 3 trial, 3,000 patients, 10,000 patients. All the data goes to the FDA. FDA only looks at the raw data. They don't look at the synthesized data from the company. So they do their own analysis, and anytime they pick up these signals, then they want to know more about these patients and the relationship to the drug that is being developed, and if there is real concern, then they will refuse to approve the drug. So As FDA is getting better and better, we are seeing less and less drugs being withdrawn from the market. So idiosyncratic DILI is a very important differential in clinical practice. It's uncommon. It's difficult to predict, diagnose, and treat. And it can occur in people with underlying liver disease, so it gets confusing whether the elevated liver enzymes are related to underlying hepatitis B flare-up or hep C flare-up or the new supplement that the patient has taken. And we can break heads on that sometimes in our conference calls. The cause of DILI, it's multifactorial. It could be different for different patients. It could be the drug. It could be the metabolism related to the host, or several things that could be related to the genetic predisposition. As of now, there's some signal with regard to HLA polymorphisms, but one group reports one polymorphism associated with one drug that cannot be replicated in a different patient group across the Atlantic. So it's become very difficult, and we are still struggling as to what predisposes a patient to drug-induced liver injury, especially idiosyncratic. I wouldn't be talking much about the details about this. I'm going to be keeping it very clinical that would be relevant for day-to-day practice. So risk of DILI from individual drugs. For us, when we want to address this question, it is very important that we get the numerator and the denominator. Denominator would be number of prescriptions, numerator would be number of cases. And it's very difficult for us to do it in US because of fragmented silos of information. Some information is with the insurance, some information is with the hospitals, with the labs. So it's very difficult to get any sense in the US. But Iceland is a small country. Everybody knows everybody. Every system talks to each other. Probably there's only one system. So most of the data from DILI, for DILI, comes from Iceland. Here you have number of prescriptions, number of patients treated, and number of cases. So they have a good sense with regard to risk of DILI among exposed patients. Here you have Augmentin. They have Imuran, Remicade, nitrofurantoin, Lipitor, Doxy. So you get some sense with regard to risk of liver injury from particular drugs. And clinical presentation of drug-induced liver injury could be anything. It could be just liver enzyme abnormalities. Patient is completely asymptomatic. But you can't call any mild increase in the ALT or AST or a one-time increase as drug-induced liver injury. So there has to be a standard definition. And if it is just liver enzymes, you need to have at least one of the following, which is 5 times the upper limit of ALT or 2 times the upper limit of alk phos, or a combination. In the absence of competing etiology, that would be the definition of DILI. And then if you have symptoms, you could get general symptoms, immunoallergic features, or symptoms related to severe liver injury, which is jaundice, coagulopathy, ascites, or even pulmonary hepatic failure. It could present in a variety of ways. It could mimic any known liver disease. So we have to be very careful because it can mimic anything. It could cause acute hepatic necrosis, such as Tylenol, acute hepatitis, such as INH, cholestatic hepatitis, Augmentin, and there's this increasingly concerning awareness about steroids that are in supplements for bodybuilding. It causes bladder cholestasis. Bilirubin can go as high as 50 with AST, ALT, and INR normal or very unimpressive. Some drugs cause NASH. This is typical breast cancer patient on tamoxifen for the last 3 years, and they have fatty liver, and you're thinking, is this fatty liver garden variety, or is this fatty liver NASH from tamoxifen, and should I recommend discontinuation of tamoxifen? Nitrofurantoin, and then these rare syndromes, presentations related to oncology drugs or immune suppression drugs, and then hepatic adenomas from oral contraceptives. It's also important to recognize the scenarios of presentation. You could have a drug and the patient develops liver injury while on drug. It's very easy to recognize, and you stop the drug and then there is recovery. This also is easy because you have a recent drug exposure, then there is a latent period, and then you develop the liver injury and the patient spontaneously recovers. Sometimes the latency could be long, and if we don't spend enough time or patient does not alert us that there's been exposure, we easily miss the drug, and then there is the chance of being re-exposed to the drug, and there is a re-challenge, and the next time the severity of liver injury may be even worse. So I think it is very critical to spend time and recognize that there is an event that happened and that needs to be better characterized. The general tendency is you're so busy, you're not as invested in this topic of drug-induced liver injury, and the patient is getting better. So there's a tendency to say, hey, whatever happened, you got better, don't worry about it. But if you are worried about re-challenge, then it is very critical to recognize what exactly happened. Unfortunately, the diagnosis of DILI is old school. It is what it is. You have to spend time recognizing temporal relationship, what happened after the drug got discontinued, what's the pattern of liver injury, how much time and effort has been spent in exclusion of competing etiology, and the drug you are thinking, has it been reported to cause liver injury before, or any chance that this was a re-challenge. So I'll give you specific examples with regard to each issue. For example, latency, it could be variable and drug-specific. For example, Bactrim and certain antibiotics, they have a very short latency period. This is classic Bactrim. Within 3 days, they get rash, they get low-grade fever, and they may even get increased serum creatinine. And oftentimes, there's these women given for either UTI or acne, and then they get presentation into the emergency room thinking, oh, maybe you didn't respond to Bactrim because you have increased creatinine and your fever, your UTI will just change the antibiotic. So that is one thing that you may want to recognize with Bactrim. INH, this is classic. We have a lot of immigrant population from Burma, almost 2,000 patients in southern Indianapolis. A lot of them are PPD positive, and they get on INH, and several months later, they have liver enzyme elevation. And it doesn't happen right away. It's like 5-6 months later into the INH that they develop hepatocellular pattern of liver enzyme elevation. And another example, long latency, is teenagers on minocycline for acne. 2-3 years later, they develop liver injury. They're on and off minocycline, and there's a tendency that they may not be on it when you are seeing the patient. And other example is the nitrofurantoin. The urologists love this drug. They put little ladies on nitrofurantoin for several years, and we have seen patients with cirrhosis from nitrofurantoin-induced autoimmune hepatitis. Amiodarone is another drug that can cause chronic liver disease. The challenge is the time to recovery. It usually improves within a few days to a few weeks, but in certain situations, you could have persistent liver test abnormalities for several months. This is one paper from DILI network that pointed out that patients who are older and those who had cholestatic type of liver injury tend to have a longer time for recovery. I've been saying about pattern of liver injury. Oftentimes residents, I ask them, so what do you think is the pattern of liver injury? And they kind of look at the numbers, and I get 3 different answers from 3 different residents. And often I feel that they try to wing it, looking at what their gut feeling is. And I tell them there's a formula, just use it. So you and I speak the same language. So if you want, you should remember about the R value, which is the patient's ALT, divided by upper limit of normal, and then the alpha's upper limit of normal, and then the ratio. If it is less than 2, it is cholestatic. If it is 2 to 5, it's mixed, and greater than 5, hepatocellular. So you get some sense that the presentation, you have the R value, which is hepatocellular, and you have a drug that is INH. so you have more comfort in coming up with your diagnosis. Or if you have an anabolic steroid and patient is on rifampin and you are thinking it is rifampin or INH and you're like, okay, this doesn't fit the pattern that I know about the drug. I need to go ask more questions. So it helps in some. Then the immunoallergic features, there are certain drugs. Thank God, this came and went. I don't know if you guys know, this was the direct-acting antiviral agent, first one to get approved. It is the biggest blockbuster. It came and went within a year. There was a lot of DRESS syndrome. And here is a case where one of our fellows published. This is the drug-induced skin and liver injury from Xarelto. Patient's rash, this was recognized in the hospital, and careful history led to recognition that the patient got rivaroxaban. This is the skin showing inflammation and the liver showing just lobular hepatitis. And it resolved spontaneously. I did want to talk about drug-induced autoimmune hepatitis. There are drugs with definite association: minocycline, methyl-dopa, hydralazine, nitrofurantoin. There are some cases of Lipitor, infliximab, the Remicade, always ANA positive and autoimmune type hepatitis. Possible, not clearly proven. Then there is possible drug supplements. These also may cause autoimmune like hepatitis. So when you're working up for competing etiology, you have to have very high index of suspicion for DILI, and then take a careful history to exclude competing etiology. Imaging studies to rule, especially if you have a cholestatic pattern, then the imaging becomes more important. If it's a hepatocellular pattern, then your serologic workup becomes more important. So you don't have to do everything for everybody. You can prioritize your workup. And there are certain situations that mimic drug-induced liver injury. The notorious is Hep C. Your acute viral hepatitis panel has only Hep C antibody. It doesn't have Hep C viral load. So if you have an acute hepatitis case where you're thinking DILI and you have Hep C antibody negative, and this is within 2 weeks, you need at least 4 weeks for the antibody to become positive. So unless you exclude acute Hep C with a viral load, your diagnosis of DILI is really at risk. And you may see sometimes you're reviewing the literature and you see a case that was published in the 80s of drug-induced liver injury from a certain drug, but Hep C was only discovered in 89 and viral load thing came out in 91. So how can you depend on a paper that's published before that, whether it was related to Hep C or the drug? So you have to be very careful in evaluating literature from the past. Hep E is increasingly getting recognized. Unfortunately, we don't have a good assay. It's genotype 3. It's a zoonotic virus. So infected pork is the way to get the acute Hep E. You could look into IgM antibody and PCR as long as you're thinking about hepatocellular DILI. EBV hepatitis is unique. It causes alk-phos elevation, and oftentimes hepatologists may not be the one who gets called for a patient with EBV hepatitis. ERCP colleagues gets called because thinking it's a biliary tract issue. And if they recognize that there's some thrombocytopenia, there's constitutional symptoms, fatigue, fever, they may alert the hepatologist that this is not really a biliary tract issue. Liver biopsy is not necessary. Oftentimes I get called from residents, hey, I have a case that I think is DILI, but we have not done a liver biopsy. Are you still interested? I said, we don't need a liver biopsy. It helps, but it's not needed. It may serve as a prognostic tool. If the amount of necrosis is very high, you know that you may be dealing with liver transplantation. So I generally reserve it to select situations where a diagnosis is not very clear and you may need some additional help with liver histology. In the DILI network, 200 patients had liver biopsy with suspected DILI. Most were acute or chronic hepatitis, acute and chronic cholestasis, and then 29% were cholestatic hepatitis. So whenever you're thinking that a particular drug is causing liver injury, you need to know what is the strength of that agent being implicated as a liver injury. On Livertox website, they are categorized. A is a drug that is well-known, well-described, well-reported to cause liver injury. More than 50 cases, including case series, have been described. And then you have category E, which is despite extensive use, no evidence that the drug has caused liver injury. Single case reports may have been published, but they are very largely not convincing. The agent is generally not believed to cause liver injury. So you are thinking of a drug, you're thinking of DILI, and if it is category E, then you have to really question yourself. But if you have a drug that is category A and you're not thinking of DILI, then it's a problem. So what do we have? Is it all cerebral, or do we have any tools to recognize a case of drug-induced liver injury? There are several scales. Most of these are used in drug development, where a company wants objective numbers, and as clinicians, we really don't need scale. It is our impression. But you could use these scales to give some objectivity to our thinking. And we'll talk a little bit about RUCAM. But in general, in the drug-induced liver injury network, we depend upon expert opinion. That's based on these things that we already talked about, which are temporal relationship and whether the drug has been reported to cause that kind of liver injury, and then the exclusion of competing etiology. We grade them on a scale where we are very comfortable with calling it definite or unlikely. These are just arbitrary percentages. So RUCAM is a score. Again, it's an objective numbering to a subjective thought process. So there's a scale, and you get a score, and based on this score, you get prediction with regard to the drug-induced liver injury. There's a downloadable link. You can download. It's a one-page sheet. It's very easy. It makes you think and organize your information. You tabulate the score, and you get some idea. Management of DILI, unfortunately, is not much. There's been a criticism for our drug-induced liver injury network. Yes, you want the patient, but you don't offer much other than collecting the data. You don't have any treatment options, and we've been struggling for years as to what would be the good treatment option for drug-induced liver injury. And oftentimes, patient is already getting better, so why do you want to intervene with another drug? And they're already scared that they got liver injury from a drug, and you want to put another drug. So it's unclear as to how we approach the treatment option. But stopping and avoiding re-exposure is the key, and that's the reason why one needs to spend time in figuring out what drug caused. Most of the times, the treatment is symptomatic, and one thing that often gets missed is the low-fat diet. When patient is jaundiced, they cannot handle fat, and they develop nausea with fatty food. So I do recommend low-fat diet, and then symptomatic treatment for itching. And you know certain drugs for Tylenol, Mucomyst, I tend to use it for any drug if there is a severe enough liver injury that the patient requires hospitalization, especially if the liver enzymes are very high. L-carnitine for valproate, cholestyramine for leflunomide. I generally use cholestyramine and Ursodal for cholestatic liver disease. The thinking is that there is a metabolite and there is the enterohepatic circulation, and then if you don't interfere with that, then the liver keeps getting exposed to the metabolite, and then it may perpetuate a longer injury. So if you are using a resin, it may absorb that metabolite and may decrease the chance of enterohepatic circulation. So that's the reason why cholestyramine is. And then steroids only for drug-induced autoimmune hepatitis. From There's an abstract from the DILI network that looked at steroids for treatment of any severe liver injury. And people who got steroids are actually more mortality. But steroids may have been thrown in because patients are so sick. So really, we don't know whether steroid causes more mortality. It's just that steroids don't work. So this is mortality from DILI versus pattern of liver injury. The initial data from Iceland, Spain, showed that perhaps the mortality with hepatocellular pattern is higher than cholestatic or mixed, but from our own drug-induced liver injury network, that didn't really pan out. But definitely for sure, if you have a mixed pattern, the mortality is lower, but hepatocellular versus cholestatic, there was not much difference. I'm going to switch gears with regard to novel drugs and atypical DILI. It's atypical because they don't behave the same way. So FDA has this accelerated approval program and breakthrough therapy designation where a drug can get into the market based on phase 2 data while the phase 3 is happening because there are no treatment options for these patients with unfortunate terminal conditions. So these programs have been created, and these are the drugs that have been approved through this process. So one new drug that was approved in February 2015 was palbociclib. It's a breast cancer drug that has no treatment options, and they have a phase 2. They did a phase 2 study. They had some liver test abnormalities, but none of them met Hy's Law criteria. Phase 3 happened. This drug was already in the market. Phase 3 was ongoing, and they had one case of liver death, which the primary investigator, an oncologist, did not think was related to the study drug. And these patients are sick and metastatic breast cancer. The liver is loaded with mets, and patient has liver-related death. It's very difficult to say whether it was the drug or metastatic liver disease. So we saw this case. And as you realize, 47-year-old African-American woman with new onset jaundice and ascites. And if you look at the liver enzymes, very unimpressive. The peak was 200 something. Look at the bilirubin, 11.7 with transaminases, very unimpressive. Alk-Phos, very unimpressive. Progressively worsening jaundice. And these are the imaging studies. She had some metastatic liver cancer, and this is over time. Look at the liver shrinking, ascites being present, and this is the coronal view, sagittal view. Look at the liver, almost pseudo-cirrhosis. This is how the explant. This is how the liver looked at the time of explant. The patient was in the healthcare space, and she insisted that more be known about this drug. So I promised that I would publish for her. And this histology showed occluded central veins, and we described sinusoidal obstruction syndrome from this drug. And looking back, even the one case that was reported in the phase 3 was possibly pseudocirrhosis. Then there is another case that we published. This is another breast cancer drug, TDM. There were some liver enzyme signals in the phase 2, phase 3. And here we had a patient who was on the treatment trial, in the clinical trial, who developed ascites, and that improved after the drug was discontinued. When the ascites was tabbed, serum ascites albumin gradient was greater than 1.1, so that tells you it's a portal hypertensive ascites. And we did the transjugular liver biopsy. To our surprise, we found that it was sinusoidal portal hypertension. And the liver biopsy showed this alternating, compressed hepatocyte plates versus dilated, and that's characteristic for nodular regenerative hyperplasia. So we described drug-induced NRH with this drug, TDM, and that was easily accepted by the oncology journal. This JCO is the premium oncology journal, and they right away accepted it. So what we learned from one patient right away, we recognized another patient. So once we diagnosed this patient, the oncologist said, hey, I have another patient participating in the trial, and all she had was thrombocytopenia. And we did an EGD, it showed small varices. She didn't have ascites, she didn't have any liver test abnormalities. And we said, if we don't stop, I do worry that she may mimic this patient in developing ascites. So we stopped it right away, and then the thrombocytopenia resolved. So what we learned from patient 1, we directly implemented in patient 2, and there's nothing in the literature that we could find. I've been saying a lot about drug-induced liver injury. This is the DILI network. It's NIH-funded, multi-centered, UO1 grant. FDA is involved, NIH is involved. There's data coordinating center. And these are the current studies, current sites. And this is the data from our network. As you see, number 1 is antimicrobials. Number 2 is dietary supplements. And these are the other class of drugs. Among the antibiotics, antimicrobials, you see Augmentin is number 1. INH, nitrofurantoin, Bactrim, minocycline, cefazolin, azithromycin, cipro, levofloxacin, and diclofenac. So think about these drugs. These are the top hits in our network. So let's switch gears and talk about dietary supplement. This is the prevalence of supplement use over time. This is the data from N. Haynes. Children, I think they classified children as about 12. I think that's why you have children in here. So the prevalence of use is increasing over time. The money that's involved in selling these supplements is in billions and increasing over time. It is estimated that half of US population uses some form of herbal or dietary supplements. They're mostly vitamins and minerals, but they also have botanical components, extracts, proteins, steroids, and then this new thing that I'm increasingly recognizing, it's called proprietary blend, so they don't even have to tell you what is in there. It's just proprietary blend. As in many countries and cultures, HDS is founded on a history of safe use in humans. Everything is natural, it must be good. It's safe, freely available. Unfortunately, they're considered as food, not drugs. Germany is the only country in the world where HDS is approved, whereas everywhere else, it's not regulated. There are some laws that have been enacted. In 1994, this is the act where they described dietary ingredients as vitamins. All the manufacturer declares that they are safe. They have no responsibility for surveillance or reporting with regard to safety. And then they can do structure function claims like calcium builds strong bones, and they can sell it for strong bones if they have calcium in it. But they don't have to do any studies. Then there's a more recent law, 2007. They said, manufacturer has to have standards in purity, strength, composition, and they don't have to claim any safety with regard to what they are putting. This is all just manufacturing. So use of multiple HDS concurrently is very common. We have people who come with bags of supplements. They don't often tell their doctors, and there are many situations where the safety of this HDS is in question. Especially anytime it's shown on Dr. Oz's show, people start taking, and this may be appropriate. Donald Trump is going to declare his medical records today on his show. So there are safety concerns. This could be any of these: cholestasis, sinusoidal dilation, adenomas, could be several organs. I do want to let you know about the most recent was Oxylite Pro. Several cases from Hawaii developed acute liver failure after taking the supplement. Prior to that, you have hydroxycut, which has the green tea extract for weight loss. Many young women develop liver failure. Then you have this concerns with how do these herbal dietary supplements develop liver injury? Is it what they have? Is it the interaction with prescription drugs? Is it contamination? Is it a chemical contamination? Is it a microbial contamination? So a lot of cases are ongoing. New York State Attorney, they did measure the supplements by buying them from GNC, Target, Walgreens, Walmart, and found that there are many products with many supplements. These are the adulterants found. You have anabolic steroids, sibutramine for weight loss, so many, sildenafil. All these adulterants are there in the supplements. In our own DILI experience, these are the supplements that the patients are taking: bodybuilding, weight loss, and several other reasons. These are the trends over time. Currently, 20% of the patients that we enroll with liver injury are related to dietary supplements, and these are bodybuilding, and these are the other supplements. Liver-related outcomes, hospitalizations. These are the conventional drugs. These are the bodybuilding and non-bodybuilding. Liver transplantation is higher with non-bodybuilding, and non-bodybuilding also have severe DILI scores. This is a case of a patient with jaundice, a 20-year-old man, jaundice, itching, no high-risk behavior. Enzymes not very impressive. Bilirubin 10, that's impressive. Serologic workup negative. Imaging studies do not show any biliary dilation. Liver biopsy showed bland cholestasis, not much inflammation. And this is what he was taking, H-Drol, which has this. Anytime you see that, you know it's going to be steroid. So this is one abstract wherein we looked features and outcomes of bodybuilding supplements. 14 products analyzed, 71 had anabolic steroids or steroid ingredients. These are dietary supplements, but they had anabolic steroids. This is another case of severe hepatitis, woman with malaise, fatigue, jaundice, taking weight loss supplement for 6 weeks. Enzymes are very high. Hepatocellular, bilirubin high, alpha is not very much elevated. Biopsy showed lobular inflammation, necrosis, and recovered without sequelae. And these are the liver biopsy findings, just lobular hepatitis. Another feature showing lobular hepatitis. And then this is the inflammation. And she was taking the green tea extract, Puritan's Pride. There's this recent paper that we published, Slim Quick. These are the case series. Patients taking Slim Quick, which has the green tea extract for weight loss, and average age, and the INR, and then the strength with which we thought that this was a case of DILI, and then their outcomes. Lastly, I want to talk about Livertox. It's a resource that is available, Livertox.nih.gov. You go to the website, it has all the things that you want to read if you are new to the field: introduction, overview of DILI, specific drug records, and then it also allows you to submit a case. And hopefully in the future it would be interactive. So this is how it looks. You just type in the drug and click search, and then it gives you what the drug is, and it has case examples, and you can compare your case with the cases that have been published, so you get with regard to latency period and time to recovery and things like that. So it makes you feel comfortable. So you don't have to go on PubMed, find different papers and summarize it for yourself. This is a premium curated content. It's like the destination for DILI. And most of the information here has been curated from the cases that we enrolled in the Drug-Induced Liver Injury Network. And you have Jay Hoofnagel, who's the man behind this from NIH, who's carefully curated all the content for anybody to use. And the number of people hitting this website has increased exponentially. It is used worldwide. So in summary, always consider a case of DILI, active role in obtaining history, temporal association, certain drugs can cause autoimmune hepatitis. Use this while you are working up your patient, and then follow the patient to assess response to D-challenge. So then you are comfortable making the diagnosis. So that's my talk. Thank you very much for your attention.
Thanks, Raj. We'll take a few questions, but before I do that, I'd like to just make an announcement. So we share your enthusiasm for liver toxicology, and so yesterday we announced a new center dedicated to that with Craig McLean, PI, the UofL Hepatobiology and Toxicology, COBRA. We didn't go into a lot of the mechanisms behind liver toxicology, but that's what we seek to do in this COBRA and train new investigators on that too. So perfect timing. I wanted to start off with one question. This is probably the most common consult we see, or question related to drug-induced liver injury, particularly at the VA, and that's regarding statin use. So my patient has abnormal liver enzymes, maybe they have NAFLD. I want to start a statin. Is it safe to use it? Or I did start a statin and the enzymes bumped from 60 to 80, so I stopped the statin. What can I do? Let's send them for a GI consult. So this is not an uncommon thing. I was wondering if you could address some thoughts on that.
Yeah. Our group has worked on this question. At least in Indiana, we've hammered every primary care physician not to worry. But we have looked at patients with underlying NAFLD with and without elevated liver enzymes exposed to statins, and we have not found any increased risk of hepatotoxicity from statins. This was a big deal in the past because of the animal studies showing liver injury when you interfere with HMG-CoA activity, but it never really panned out. And also, the package inserts that came with the statins in the beginning, they recommended monitoring liver enzymes, so everybody's so wired in for liver injury related to statins, but then after several years of use, there has not been much worry or concern with regard to statin hepatotoxicity. Yes, it can happen. It's rare, but not as much as we should be worried. But there's no incentive for the drug company to go back and revise their package insert and tell providers that they don't need to monitor. So the package inserts, some have been updated, some not, and the concern continues to linger at the grassroots level. But in general, our recommendations to primary care physicians or any other specialties, cardiologists, we do get the consults too, that we are not concerned about statin hepatotoxicity, and statins may be continued as long as the enzymes are less than 200 range and there is no increase in the direct bilirubin. So anything below that is either fluctuation from the underlying NAFLD or some enzyme fluctuation from the statins themselves, but there's no need to discontinue as long as the direct bilirubin is normal. Yes. Thank you. Yeah. Yeah. You bring a very good point. We do have the same issue. At least now we are a consortium. We are 18 hospitals. At least that has been standardized. So our upper limit is 45 ALT. I generally tend to use 45, but for the benefit of audience, practice criteria, which is what the ASLD defines as normal ALT, is 19 for a woman and 29 for a man. So anything about 29 is abnormal. So if you have a lab that says 75 is upper limit of normal, then you have to really, roll your eyes. That's really not normal. So I find a compromise with 45. Oh, wow. Oh, my God, you make me...
What I've been dying to see is if we can fit Vuppalanchi in a baseball bat. I don't know if this is a longer bat than the speakers normally get, but it did fit. And so, as you know, Louisville is known for many things: baseball bats, bourbon whiskey, race horses, etc. And so there's a tradition here at the university to present our grand round speakers.
Thanks, man.
With a
Thank you.
baseball bat.
I'm humbled.
Thank you. Have a good day.
Thank you. Oh. Hey, this is amazing. I didn't know that.
I don't think we have cricket. Beating us with the bat, I guess.
Did I get my thumb drive?
It's still in there.
Okay.
Right to the heart.
You don't mind, please?
Yeah, sure. Xavier, the ones he takes too. Very good at that.
And then we like to get one of those with you. Oh, really? Oh my God! No, I haven't played baseball, but I can do the cricket thing.
Yes, if you want.
Scoot over this area, Mark.
Gotta turn it back, kind of angle this way. There we go. Perfect. One, two. Actually, we can get one with the baseball.
May I get my thumb drive?
Yes.
I'll wait for you to get here.
It's unpopular.
Thank you. Mm-hmm.